Good morning. Welcome to the WHO Africa Media Briefing, which is taking place in collaboration with the APO Group. My name is Dr. Mary Stephen. First, some housekeeping. You can listen to the press briefing in either English or French. To do that, please go to the bottom right-hand corner of your screen and select your most preferred language. Vincent, please tell our French journalists.
Hi, it's not Vincent, it's Kaï. Merci Mary. Bonjour et bienvenue à tous à la conférence de presse de l'OMS Afrique. Vous pouvez choisir de suivre cette conférence en français en cliquant sur le globe interprétation en bas à droite de votre écran et en choisissant donc la langue française. Merci Mary et bonne conférence.
Merci beaucoup. Now joining us from Brazzaville, the Republic of Congo, is Dr. Mashidisho Moeti, the WHO Regional Director for Africa. And now I will turn over to Dr. Moeti to introduce our other panelists. Good morning and welcome, Dr. Moeti.
Yes, good morning. Thank you very much, Mary, and a very good morning, good afternoon, bonjour, and welcome to all the journalists who are joining this press conference today. So today we'll be discussing the highly anticipated launch of funding for the rollout of the first ever malaria vaccine to millions more children in Africa, and also share some positive news about a substantial increase in the uptake of COVID-19 vaccines on our continent. There will also be a brief update about new confirmed Marburg cases in West Africa. So I'm really pleased to be joined for this press conference by Mr. Thabani Maposa, who's Gavi's Managing Director of Country Programs, who has responsibility for the Vaccine Alliance's operations in 73 countries. A very warm welcome, Thabani. Then also with us today is the eminent malariologist, my colleague and sister, Professor Rose Leke, who's the Emeritus Professor of Immunology and Parasitology at the University of Yaoundé, and a fellow of the Cameroon, African and World Academies of Science. A very warm welcome to you both. The news of Gavi's multi-million-dollar funding to countries to expand access to the world's only malaria vaccine marks a key advance in the fight against one of Africa's most severe public health threats. One child dies every minute in Africa from malaria. So by the time we finish this one-hour press conference today, 60 more young lives will have been tragically cut short on the continent with catastrophic consequences, not only for families and communities, but also for national development. Countries in sub-Saharan Africa bear the brunt of the burden of malaria, accounting for more than 9 out of 10 of the over 240 million global cases in 2020, along with most of the more than 600,000 reported deaths. So this financial support from Gavi provides a landmark opportunity for countries to introduce or further the rollout of the malaria vaccine. It will initially benefit Ghana, Kenya, and Malawi, the 3 countries that began piloting delivery of the vaccine in 2019 before being expanded to other eligible endemic countries. The pilot countries have vaccinated more than 1,300,000 children since vaccination began and have reported a 1/3, almost 30% drop in hospitalizations of children with severe malaria. They've also seen, after 2 years in the areas where the vaccine was piloted, an almost 10% reduction in child deaths in the age group that is eligible for the vaccine. So it delivered at scale. Millions of new cases could be averted and tens of thousands of lives saved every year. We were encouraged to see that the demand for the vaccine is high, even in the context of COVID-19, with the first dose reaching between 73% to over 90% coverage. This reflects that really parents, caregivers, and communities know all too well the tragic toll that malaria takes and are eager to protect their children from this deadly disease. But for now, supplies remain limited, and achieving equitable access for all eligible vaccination. So lives are at stake, and I can't stress enough the need for increased attention from donors, from health leaders, and manufacturers. WHO is fully committed to working with partners to find ways in which to boost manufacturing capacity, increase vaccine access, and ultimately change the trajectory of this devastating disease. For COVID-19 vaccines, I'm pleased to be able to share the news that uptake of doses increased by a significant 74% in June compared to the previous month, breaking a 3-month sustained decline. This is a result of mass COVID-19 vaccination campaigns being conducted in 16 countries. With a further 19 such campaigns planned for July, we anticipate more improvements in terms of coverage going forward. Coverage has reached about half or 50% of vulnerable groups and 21 or just over 1/5, 21% or just over 1/5 of Africa's general population. Among the 14 countries in which more than 10% of populations had previously completed the primary series of vaccine doses, 6 have now surpassed this benchmark in July. With tens of thousands of new COVID-19 cases still being reported across the continent every week, this increase in vaccine coverage is extremely heartening evidence of a continued commitment by African countries to the vaccination agenda. The fact that vaccination remains our most effective tool in the response to COVID-19 on the continent and in the world cannot be overemphasized. So we encourage very much this continued effort, and we are working with WHO, with other partners to support our member states to continue to make progress. Turning now to Marburg disease, this week, Ghana has declared and confirmed its first ever outbreak of the deadly virus after a WHO collaborating laboratory corroborated earlier results. Ghana has reported 2 confirmed cases, both of which resulted in death. So the Marburg, which is in the same family of viruses as Ebola, is highly infectious and can be fatal in a large percentage of cases. As yet, there are no vaccines, no treatments, making immediate and decisive action to curb any potential spread critical. This is only the second time that the zoonotic disease has been detected in West Africa after a single case was confirmed in Guinea last September. And genomic sequence analysis of the virus from Ghana suggests it's related to that earlier reported case. However, more analysis is needed to understand what is behind this link and the possible health implications, public health implications. And we are very pleased to see that Ghana is responding swiftly and effectively, and our country team, as well as our emergencies program, is providing support together with other partners. A total of 108 contacts were identified, including healthcare workers and community members. Unfortunately, following 21 days of observation, all of these are currently well. Neighboring countries are on high alert, and we are supporting Ghana to bolster surveillance, testing, and tracing, and to make preparations for the safe management of any new cases that may be identified. So I'd like to conclude by again welcoming very warmly my fellow panelists and thanking you, journalist colleagues, very much for your attention. And I look forward to our conversation today. Thank you. Back to you, Mary.
Thank you. Thank you very much, Dr. Moeti, for those good news about the malaria vaccine, as well as the uptake in COVID-19 vaccination. Definitely lots of hope for us in Africa. And now turning to you, Mr. Tabani, could you please tell us about the specifics of the Gavi funding opportunity and the application process? Welcome, Mr. Tabani.
Thank you, Dr. Mary, and thank you, Dr. Moeti, for the invitation, and Honorable Professor. It's a pleasure to be with you in this panel. Thank you for all your work and all you do for the continent of Africa. As an African, I do not have to tell you about the significant risk that malaria brings to our continent. Many of you would have experienced it firsthand. I remember when we were dealing with COVID in the first days, there was a question in some countries in Africa, do you know anybody who's been affected by COVID? That was when the disease burden was still a little bit low. But with malaria, it is exactly the opposite. Would you know anyone who has not been affected by malaria in their family, in their community? It is a disease that is so pervasive and one that kills many African children. 260,000 African children under the age of 5 die annually. The interventions like bed nets have saved lives, and the global health community continues to work with governments and civil society across Africa to fight malaria. But now we have a new tool, a tool that we are all absolutely excited about, the malaria vaccine. The reasons for being excited about this tool are many, but one of them is that if you have worked on something for a long time and you finally get it, you cannot hold back your excitement. And with malaria, this is something that has been worked on for a number of decades. So this is really an important moment for Africa and for the children of Africa. As Dr. Moeti pointed out, Ghana, Kenya, and Malawi were the pilot countries, and they have used this successfully and gotten us to this place where we are. Gavi's board has approved an initial investment of $155.7 million US dollars to support this vaccine. And we have an additional support of $56.6 million through a de-risk mechanism with GSK and a partner, which was MedAccess. This vaccine will save lives. However, as Dr. Moeti also pointed out, demand will be greater than the volumes that we are able to supply. Our challenge during this critical phase is to ensure the doses we have available are used as effectively and equitably as possible. With this in mind, Gavi today is opening an application window for malaria support. Ghana, Kenya, and Malawi will be the 3 malaria vaccine countries that will receive and apply for this funding from now. These 3 countries already have experience of rolling out this vaccine, meaning that they will require leakly to set up their systems to prepare for receiving the vaccine. Of course, we also want other countries with moderate to high burden of the malaria disease to apply. And the expression of interest is something that we also have opened for these countries to be able to communicate what they need so that we can plan better with them and support them effectively as well. We face many challenges. Production will take some time to increase. We won't be able to reach everyone right away. More investment in technology transfer will be needed as well. I'm optimistic that we will make this happen. The introduction of malaria vaccine is truly a historic achievement. It is our sincere belief that getting these vaccines to the arms of as many children as possible, as fast as possible, will make a dent to this killer disease. I'm excited about where we are, and Gavi is excited, and we look forward to working with WHO, technical specialists, and other partners across Africa to make this a reality. Dr. Moeti, back to you. Thank you.
Thank you very much, Professor. Thank you very much, Mr. Tabani. Sorry, with that good news, this definitely brings hope for the African child. We welcome the malaria vaccine on the continent. And now turning to you, Professor Leke, could you please tell us about why it's critical to ensure children in the greatest need have access to this vaccine? Good morning, Prof, and welcome.
Thank you very, very much. And good morning to you. Good morning to Dr. Moiti. Good morning to Dr. Tabani. And it is really a pleasure for me to join both of you to be part of this briefing on the international funding opportunity that will enable countries to introduce the first malaria vaccine to more children at risk. First of all, really, I'd like to congratulate WHO and Gavi and partners for this significant step forward for this impactful and life-saving vaccine. Yes, it is. And we need this vaccine now more than ever. We know that the burden of malaria is devastating to communities and countries across the African continent. You hear the facts, like Dr. Moiti said. One child dies of malaria every minute. Yet, the reality of living with the daily risks of this disease and its consequences is difficult to fully convey. After recent decades of progress, we now see that malaria is getting worse in many places. We can see that in the malaria report, the global malaria report, and this threatens our well-being and future potential. And really, this is unacceptable. As a malariologist who has devoted my professional life to fighting malaria, I do recognize this long-awaited malaria vaccine for children as a breakthrough for science, child health, and malaria control. It is a project that at scale, using this vaccine could save tens of thousands of young lives each year. But we'll need increased supply of the vaccine so Africa can reap the benefits of this additional tool for malaria prevention. We remember this is the first life-saving malaria vaccine and the first vaccine recommended for use against a human parasitic disease of any kind. So from the pilots, it has been mentioned, we know that the vaccine is safe and can reach children through routine child health clinics. And it has substantial impact to reduce child hospitalizations from deadly severe malaria. And because the vaccine reaches, in this pilot, 80 to 90% of the children, it is reaching children who are not using other forms of malaria prevention, such as insecticide-treated bed nets. And given the public health situation and the currently constrained supply of vaccine, it is an ethical imperative to pursue ways to accelerate increased supply to meet demand as soon as possible. In parallel also, I recently joined colleagues in malaria, immunization, and ethics from across the continent and globally to advise WHO on a framework to allocate the limited supply of malaria vaccine in a fair and equitable way until supply constraints can be fully resolved. The resulting allocation framework would therefore guide decisions at global and country levels to ensure that children living in highest risk areas across endemic countries are prioritized to receive the vaccine until the supply fully meets the demand. And we hope that this will not be too long. And so with WHO, I really urge the African community and global partners to work together to increase the supply of this and future malaria vaccines that may become available, and to help reverse the troubling trends. This vaccine presents an opportunity to strengthen malaria control, and it will lead us towards eradication, improve child health among some of our most vulnerable populations. I thank you.
Thank you very much, Professor Leke. This malaria vaccine will definitely be a game changer in the prevention and control of malaria on the continent. So thank you very much. And now turning over to journalists, you have heard from all our panelists. It is your time to ask your question. To do this, please use the Q&A function on the Zoom platform. Tell us your name, the name of the media organization you represent. If you want to go live, kindly indicate by raising your hand and also informing the team in the Q&A function. So we have additional experts that will answer your questions. And these are Dr. Kalu Apaka, the team lead for strategic planning and policy in the communicable and non-communicable disease cluster. We also have Dr. Opeyo Ogundoron, the team lead for epidemiology under the COVID-19 response. We have Dr. Fiona Atuhube, the vaccine officer at the regional office. And finally, Dr. Solomon Walder-Sadiq, who is the emergency response officer. So they are all available to respond to your question. Paul, I understand you would like to ask your question live. If you're ready, please go ahead.
Yes, thank you very much. And my question has to do with the malaria vaccine itself. While it's being regarded as an advancement, I would like to understand the clarification regarding the difference it makes, especially in areas where it has already been deployed. We heard that there was a reduction of 10%. I would like to know whether this, especially from Gavi, whether this is adequate enough and whether there are still any ongoing efforts to improve the effectiveness of malaria vaccines, considering the increased high number of malaria deaths that will still be happening in spite of the vaccine. Thank you very much.
Thank you, Paul. Mr. Tabani, please, you can start with the last part of the question on the availability of the vaccine, but also I would like Professor Leke to weigh in on the effectiveness and the kind of impact we have seen with the pilot.
Thank you. It is important here to clarify, and maybe first and foremost to say that it is better to be protected and to reduce the number of children that are affected than not to do anything at all. But supply is the problem, not the funding. Gavi is working with WHO and others to improve the supply constraints and challenges. At this particular point, I would also like to point out that the development and efforts on other malaria vaccines has not stopped. But this is the best tool in the vaccines world that we have for now, and we could not hold it when there is a continent and communities that are suffering. But the efforts of continuing to find something that is more effective do not stop, and they continue to be ongoing.
Professor Leke?
Thank you very much. And as we heard, there's so many deaths, like in 2020, about 500,000, children in Africa died. Dr. Moiti told us by the time we end here, there'll be about 60 children gone from malaria. And these trials, they were first, don't forget, you have vaccine trials that went on from 2009 to 2014, and then the pilots that were done in Ghana, Kenya, Malawi. So we really have the evidence there that if this vaccine is introduced broadly, no matter what anybody says about the 10% or low efficacy, whatever it is, if it is really introduced broadly, it will translate to thousands of lives of these children saved. That evidence is there, and that's why we're putting it forward today. You know, the children in our areas, about 20 to 30% of them, you know, the death is due to malaria, even related anemia, severe anemia, and so on. So this is going to save thousands of lives. We have the evidence for that, and that's why we're here today to say this vaccine should be used, and we need more of it than we will be getting.
Thank you, Professor Leke. Dr. Moeti, do you want to weigh in from WHO perspective?
Yes, thanks very much, Mary. I'd just like to very much agree with my two fellow panelists and to say, you know, over and above cutting the mortality. So if you have 30% of children that would have been hospitalized with serious illness being prevented, that's huge as well in terms of hospital occupancy, the costs in the health system. You know, a couple of colleagues have said how common malaria is in African communities, especially in the high burden countries. We almost accept it as a matter of course. Of course, children will get malaria. And if we count the cost of that, having a seriously ill child, what it means, mom must be looking after the child, what it does to the family. I think we need to count the cost very broadly to see that this burden goes well beyond the number of children that will be saved. And if I may, because we're also very used to this disease, you know, in many other societies, if you talk about 10,000 children dying in a year, that would be amazing. It's shocking. It's something that really would need urgent intervention. So I think that if this is the tool we have today, it's very important that it becomes available. And I also know that there are other attempts to find more efficacious vaccines. One company, BioNTech, that's working on COVID-19 vaccines using mRNA technology, have said they're also going to be investing in looking at that as far as malaria vaccines are concerned. So I'd just like to add my own voice to say it's huge. It's a tool that will make a difference. Let's go for making it available as widely as possible. Thank you.
Thank you very much, Dr. Moeti. Yes, we need the tool. I remember about 10 years ago, I lost my niece to malaria. So we need every tool that is available for the response. Now we go to the question from AP Maria Cheng. And this question is coming to you, Mr. Tabani. Is there any date when you expect the malaria vaccinations to actually begin? Will that be early this year or next year?
Thank you. I think it is important to note that malaria vaccines have already begun in the pilot countries. I think maybe in a more nuanced way related to the timing of this window specifically. As we said, the opening of the application is for the 3 countries now, and they will begin getting the next set of vaccine sometime in 2023.
Thank you very much. Nikki, are you ready to go live with your question?
Absolutely. Thank you very much, Dr. Mary. And my question is, what are the factors responsible for the sharp rise in transmission of diseases from animals to human beings? That's my first question. And my second question is, when you talk about Ghana, Kenya, and of course, Malawi, do you think these countries, of course, will now start let's say, creating their own capabilities of manufacturing these vaccines in the future? Thank you.
Thank you. I pass this question to you, Dr. Moeti.
Okay, thank you very much. I mean, I think that we think that partly their surveillance systems in countries are improving, are better. There's been a lot of investment in surveillance systems in countries, partly related to the COVID-19 pandemic. So the detection of such diseases is continuing to improve, which is a good thing. We need to really get a good picture of what's going on in terms of these illnesses. And then the interface between animals, especially wild animals, but animals and humans is expanding, as we said last week, because of the way in which life is evolving. So the expansion of transportation into areas that were in the past remote. We continue to see, of course, that there are circumstances under which families are continuing to be in contact with animals through hunting, through the need for protein, etc., and the movement of people, and sometimes the fact that people move from one area to the other and have to move through areas where there are contact with animals is increased. In fact, we just have to accept that the interface between animals and humans is getting closer and closer, is broadening, and therefore our awareness and the tools that are developed to stop the transmission or the skipping of disease from animals into humans need to be very much more sharpened, including through vaccines.
Thank you very much, Dr. Moeti. And the next question is coming from Joseph Mbeng from Eco Santé in Cameroon. The first part of the question, Professor Leke, I would like you to answer, and Dr. Moeti will answer the third question. So he has about 3 questions. When will the malaria vaccine be available in Cameroon? And the second part of the question says, what are the conditions for administration of this vaccine and how can it be funded? So the last question will go to Dr. Moeti. What is WHO Africa planning to boost COVID-19 vaccination in the Africa region? So let's start with you, Professor Loki.
Let me, okay, unmute it. Thank you. When will this vaccine be available in Cameroon? Good question. Number one, for this year, like Gavi said, the applications can go on between now and September for those pilot countries. That is Ghana, Kenya, Malawi. So they apply between now and September, as I got from Gavi. But countries are open like Cameroon. I know we started talking about it already. The EPI in the NITAG about applying for this vaccine. I think we have, like Gavi is saying, about till January, and it will be open for us in January. But discussions are already going on, I must say, with the NITAG and with the EPI to talk about this vaccine. There've been meetings about it. So to assure him that Cameroon is discussing this, and as soon as we can get in line with the others and it's our turn, we will get the vaccine, depending also the distribution on the framework that was developed.
Thank you, Professor Leke. Dr. Moeti, please.
Yes, thank you very much. So WHO in Africa, we're working very closely with a range of partners on how to support those countries that are lagging behind to accelerate their COVID-19 pandemic vaccination. So we have expanded our team. We've sent to the countries that are lagging the furthest behind, in fact, additional technical expertise in order to help them on the ground, on the spot, with updating their planning, reviewing where they've reached in terms of coverage, ensuring that all the aspects of the delivery campaigns are well planned, well executed, well funded, ensuring that the supplies get out into the areas where the vaccination has to take place, the mobilization of the community. This is something that we're doing with partners like UNICEF, ensuring that people are well informed, and supporting the logistics of ensuring that the vaccination sites are being established. So what we are encouraging at the moment is to continue with several rounds more of mass campaigns. So the catching up that I referred to really was the result of having gone back to the idea of getting the vaccine out to people. There's a lot of concern I'm aware of about now integrating these campaigns into regular service delivery. And in some countries where this has been attempted, this explains some of the reduction in the coverage of vaccines. We are particularly as well encouraging countries to target the most vulnerable people, that is people who are elderly and those who have some conditions, pre-existing conditions that make them more vulnerable to severe illness with the vaccine. And one of the biggest areas in which to work is advocacy with the population, making sure that people get the right information, people know where to go to get vaccinated, advocacy with the national leadership around acquiring the financing that's needed to manage the vaccination campaigns. We're supporting countries in terms of how to also work on ensuring that the money that's available is sent out to support the vaccines, including using digital technology to get money out for these sorts of campaigns. So we are working with a range of partners to really accelerate the process. In addition, we're helping countries look at where is it most appropriate to start the integration. So for example, because this is mainly the most important target groups are not under 5 children, where we are accustomed to having vaccination services being well utilized in our region, but it's mainly adults, the elderly. So we're having to re-strategize about where to reach such people. We're targeting in some countries people living with HIV and some of the existing community-based service access interventions that are in place. And eventually our intention is to support them progressively living with this vaccine, including in terms of vaccination, a more integrated approach. But I'd just like to emphasize, for now, please let's do the catching up with some well-targeted campaigns to prevent severe illness and to prevent people dying of this illness. Thank you.
Thank you very much, Dr. Moeti. And we are also joined by additional experts from Gavi, Mr. Stephen Sosla, the head of vaccine program, and Mr. Jala Abdul Wahab, director of vaccine programs. So they are available to also answer additional questions on vaccine. Roland, are you ready to ask your question live? Roland? Okay, so if you're not ready, I will move to the next question and then I'll come back to you. So the next question is coming from Science and Dave. And this question is coming to you, Dr. Solomon. Is the West Africa region ready to contain the Marburg virus? With the outbreak of 2 diseases, monkeypox and Marburg in Ghana, do you see anything wrong with the country's disease control? Then the last question is, should neighboring countries prepare to tighten borders? Dr. Solomon, please.
Thank you very much. It's a very good question. Yes, I think most countries in the African region are striving to strengthen surveillance, especially after having the lesson from the Ebola outbreak in West Africa. A number of countries have intensified their efforts to strengthen their preparedness and capacity for detecting and then, of course, promptly responding to outbreaks like Marburg, Ebola. However, we are still have not yet reached a level, or the countries have not yet reached a level required to really be in a good position to early detect and then immediately respond to the countries. So we have to continue working with the countries, alerting them, and making sure that all efforts are made in confirming and then responding to the countries. But we can say that we have gone a long way compared to where we were in terms of preparedness and response capacities. I don't think that there is anything wrong with the health system in Ghana. In fact, identification of these types of outbreaks and diseases. Detection and confirmation is what is required. As we have seen, the region, countries in the developing nations especially are facing an increasing trend of this transmission of zoonotic diseases, as Dr. Moeti has mentioned today and in the last emergency conference as well. So we have to take it as a positive identification of these outbreaks, and confirmation should be taken as a positive development and strength, not as a problem. I will stop here, and if there is any more clarification, I will come back again. Thank you.
Thank you very much, Dr. Solomon. Yes, most countries in Africa deal with multiple outbreaks. So early detection is a sign of strength, not weakness. Roland, if you are ready, please ask your question.
Hello, good morning. Yes, considering that every child in sub-Saharan Africa has been exposed to malaria, are they not already immunized? What's the difference? What difference does this vaccine make from that perspective? And then most probably the next question, how do we also ensure and dissociate science and conflict of interest when we know that the very persons researching and promoting this vaccine is jointly the greater funder of the body controlling the World Health and the distribution through Gavi?
Okay, so your question, Dr. Moeti, maybe you can give it a go first, and then we can have one of the Gavi team to answer, Abdul Wahab, after Dr. Moeti.
Thanks very much. So the question you're asking is, because exposure is so frequent, does that mean that all children will have immunity and therefore we don't need a vaccine? That's what I'm understanding. I mean, I think so. If we look at the numbers in terms of illness, severe illness and deaths, it's clear that being previously exposed does not confer immunity to children. And that's what is making the availability of vaccines very, very important. I think, you know, young children, very young children, newborn children clearly are not immune, and even children who've been exposed, this immunity is not lifelong, so continue to be vulnerable to getting malaria, particularly in high burden countries of the number on which WHO has been trying to work for a number of years now to have an impact on the disease with rather limited success. So we do think that if there can be an effective tool of a vaccine of the type that this pilot has shown in terms of the outcomes and the impact, is something that needs to be actively pursued in terms of rolling out this vaccine and further research to be carried out to find vaccines whose efficacy is even higher than this. I think this is very important, not to have the impression that malaria is something that we live with all the time, and for that reason we are immune. I think that's something that's very important to address. Thank you.
Thank you, Dr. Moeti. And the Gavi team, Mr.
Thank you.
Abdul Wahab.
I will step in here on this one, and I will take it. Thank you. I think I may need clarification on the question, but I'll repeat what I thought I understood as I try to answer it. I got a sense that there was an issue around conflict of interest for those developing and rolling out, or for the funders, as it were. I think that it is extremely important, especially in the context of malaria, to really recognize that both the development and the testing has very much involved African scholars and academics. And by building conspiracy theories, we are really, sadly, not recognizing our people who have invested a lot of years and a lot of time. Professor Rose is an expert in this. Helen Rees is an expert in some of these things, and all of these people are African. And if ever there was a time when we will say an African vaccine led by Africans, malaria will be one of those vaccines. And I think we should not detract from a moment of pride for the African continent by bringing conspiracy. I just want us to really celebrate the intellectuals and the African scholars who have contributed to this.
Thank you very much, Mr. Tabani, for that elaborate answer on the issue of conflict of interest. And this next question is coming from Dorcas from BBC. The first part of the question is coming to you, Dr. Fiona. Which governments have included this vaccine in their routine immunization programs? So talking about COVID vaccine now, not malaria vaccine. And then the second part of the question is coming to you, Dr. Solomon. What is the status update of WHO's investigation into the disease reported by Tanzania? Their Ministry of Health has established the disease as a field fever or leptospirosis. Any update from WHO? So let's start with Dr. Fiona first and then Dr. Solomon.
Thank you very much, Mary. So I should say that all countries on our continent, apart from Eritrea, have actually included a COVID-19 vaccination as part of their routine immunization. What we are seeing as campaigns and other strategies to roll out this vaccine are just part of the usual routine immunization program. So the vaccine is being run by the EPI programs, the immunization programs in the countries. Probably if the question was referring to which countries are not doing campaigns, perhaps, we have a few countries that have not run this vaccination through campaigns, but are vaccinating strictly in their facilities and are not going out of their facilities. So we have a few countries like Cape Verde, we have a few like Senegal, but generally all countries on the continent, apart from Eritrea, are vaccinating through their routine immunization programs. Over to you, Mary.
Thank you very much, Dr. Fiona. And Dr. Solomon, on the case from Tanzania.
Thank you very much. Currently, there are no new cases, so it stands as 20 cases which were confirmed. But what is new is that another 15 samples were retested in Sokaine University of Agriculture, which is a renowned center for leptospirosis, and it was found to be positive. So with this confirmation, it is likely to be leptospirosis outbreak going on. Currently, there is a team doing further investigations on active case finding and trying to at least do more investigation on the source of infection. And WHO is part of this team. And we are working together with the Ministry of Health in making sure that there are no more cases and we are not missing any other possible cause for this outbreak. So we are working together with the Ministry of Health. Thank you. Over to you.
Thank you, Dr. Solomon, for the update. And the next question is coming from Stephen Pieper from Deutsche Welle. And this question is coming to you, Professor Leke. How accurate are current diagnostics used in Africa at dictating severe cases of malaria in children? What is the need for more accurate diagnosis of severe malaria in children in areas where the disease is endemic? And what could a more accurate diagnosis of severe malaria mean for children's health if, say, an infection like bacterial sepsis could be identified more quickly as the cause of this illness, because severe malaria could be ruled out? So let me start with you, and Dr. Kalu should prepare to complement on this question.
Thank you. Am I muted? Yes. Thank you very much. You're talking about diagnostics now for malaria. how, accurate are they? For diagnosis, really, microscopy is the gold standard. We always say so. But there are now rapid diagnostic tests that were developed, as you know, the RDTs. And this because microscopy in certain areas, they don't have, there are so many constraints where you cannot do quality microscopy. And so the RDTs are also faster. So we have these two now for diagnosis. So the rapid diagnostic tests then are used a lot, in rural areas and countries. And these are pre-qualified by WHO to make sure that, their sensitivity is really high. So you have this rapid diagnostic test. And sometimes you yourself in the lab can do it, do your microscopy and test it with the rapid test to see which one, if there are any faults with your RDTs. So short of it is there are RDTs, microscopy is still the gold standard. And in many countries like mine now, they are training more and more microscopists so that we don't forget that this is the gold standard, as well as sending out a lot of RDTs in areas where you cannot do quality microscopy. So the two of them would always go together to make sure that we get accurate diagnosis for malaria.
Thank you, Professor. Yes.
Yeah.
Okay.
Was there anything else? I think that was
that's fine about diagnostics. Yeah, I wanted to ask if Dr. Kalu has any addition on this question.
Yes, Mary, thank you. Thank you very much. We'd just like to add that questions are also asked about the severe malaria and diagnosis of severe malaria. Like Professor Leke has said, microscopy is the gold standard detection of the parasite. That shows malaria parasite is there and causing sickness. But that diagnosis, that detection of malaria parasite does not say how sick that child is, talking about severe malaria. It depends on the diagnostic capacity of the health worker to classify this child quickly as severe and manage it as severe malaria based on WHO's technical guidance. Having said that, we know that there are so many innovative approaches being tested, and one of them or two will be published today or tomorrow. One is handheld tool to detect what is medically called retinopathy in children with severe malaria. That is a kind of damage or reflection of the malaria problem on the inside the eye. That handheld tool is said to be able to detect this damage of the eye in children with severe malaria, and therefore able to improve the early detection of severe malaria cases and their management. But we need to caution that that not every severe malaria will develop that damage to the eye. And not every retinopathy or damage to the eye is caused by malaria. That is one. Two, yes, this handheld tool, when we see the publication, WHO will subject it to its normal process of reviewing innovations. And if it is effective, efficacious, and safe, of course, through that process, if it meets all the standards, WHO will recommend it for use. Until then, it is at the level of innovation, and we encourage this kind of work to go on. We particularly look forward to the publication that is coming out. Thank you.
Thank you very much, Dr. Kalu. So much good news about progress with malaria prevention and control today. Thank you so much. Thank you. Elizabeth, I understand you want to go live. If you're ready, please ask your question. Elizabeth from The Guardian. Okay, while you're getting ready, let me ask the question from Pratik Power. And this question is going to the Gavi team. GSK promised up to 15 million doses of RTS annually, but the supply hasn't matched that number. What are the bottlenecks? Mr. Tabani, please, and feel free if you want to pass any question to your team.
Thank you very much. I think that we are still in the process of tender, which is pending, and it's a sensitive process. As such, I'm not at liberty to say what are the final figures until the tender is complete. And we can come back to answer that question once the tender is public. But a good business practice guides me not to talk about something that is a tender. But we do know that supply is indeed limited.
Elizabeth, I'm back to you again. If you're available or unready, please ask your question. Okay, so I move to the next question. And this question is coming to you, Fiona. On the increased uptake of COVID vaccine and the mass campaign, which countries have shown the highest? Most successful uptake in the last few weeks. And what lessons can be learned from these successes? So the countries that have shown the highest, and then what lessons can we learn from the countries that are successful? And what are the challenges in the countries still lagging behind? And secondly, what are we seeing? Where are we seeing an increase in new COVID infections on the continent? And do we know what factors are behind this? So the second part, I will leave it to Dr. Gunderon. You answer the vaccination question, please. The successes, which countries are doing well, and what are the lessons?
Thank you very much, Mary. Very interesting question. So we've actually, like Dr. Maweti mentioned, seen a lot of success in the past few weeks, and much of this is coming from the mass vaccination campaigns that we've seen. So we've seen countries like Liberia, Ethiopia, Uganda, countries like Zambia, Sierra Leone, Tanzania, Chad. A country like Guinea has really made big strides, Sao Tome and Principe. So most of these countries were less than 10% just a few months ago. And after the mass vaccination campaigns, we've seen coverages move by even 5-6 times from what they had. So what are still the challenges and constraints, or well, let me start with the lessons that we can learn from these countries that have made significant progress. We all know that there's this COVID-19 vaccine delivery partnership made up of Gavi, UNICEF, and WHO with other partners, which has done tremendous efforts in high-level political engagement in these countries. A lot of funding has been brought to the table, and this has also enabled countries to vaccinate more. We know that vaccine doses are no longer a problem. We have more than enough doses and donations. We thank the Western world that did this through the COVAX facility. And for countries that are still lagging behind are countries we are still seeing inadequate political will. We still have countries whose politicians do not want to talk about COVID vaccination or are not talking to their citizens about it. We also have countries where we do not have the visibility. One of the challenges we see is the low visibility on the absorption of funds available. Funds have been made available to the countries, but then we do not see what they are doing, what these funds are doing in increasing this coverage. But we have many countries where we have health workers that have gone on strikes because of delayed payments of their allowances, yet the funds are available in countries. But also the insufficient planning for the COVID-19 vaccination activities at sub-national levels. Most of the planning that we saw when COVID vaccination started was at national level because of the dynamics of the pandemic. But all the work happens at the grassroots, at the service delivery points, in the communities, in the facilities with the healthcare workers down there. So if the planning does not happen at that level, which we call micro planning, if it's not done well, then we get into problems. So our way forward right now is we've prepared, we have enough technical assistance that we are sending to countries. Many partners are sending out technical assistance to countries. Funding is available, the doses are available. We are still doing the high-level political missions to talk to different heads of state, and the commitment is increasing. So to see how we increase this implementation in the different countries, but also like Dr. Moeti has mentioned, the integration of COVID-19 vaccination with other planned mass vaccination campaigns or other activities that are taking place in countries. Over to you, Mary. Thank you.
Thank you very much, Dr. Fiona. And then Dr. Gundaran. Okay, actually, the question is from Lindsay from New York Times. I would like you to answer the second part of the question on where we are seeing increase in COVID infections on the continent and what factors are behind it.
Okay, so thank you very much for the question, Mary, and to Lindsay. Where we are as of today with the COVID-19 pandemic, we're seeing something of an 8-week plateau in the number of cases, which is somewhat less than what we've seen in previous waves. Having said that, we're seeing an increased number of cases being reported in 3 particular countries. So in the northern part of the continent, in Morocco and Tunisia, and also in Equatorial Guinea, these 3 countries are the only countries as of date that are currently in resurgence. We also see, when we look at the number of cases per population, we see a high number of cases reported in Seychelles and Cabo Verde. But as we've seen with these small island countries, regardless of this high per capita incidence, they have quite good capacities to handle this type of increase. So where we'll be seeing the highest concerns would be in those 3 countries, Equatorial Guinea, Morocco, and Tunisia. Having said that, what we've seen in the past 2 months or so is this quick return of, or quick turning of curves, where we've seen upsurges in many of the countries. And we're seeing that in Morocco, where for a 4-week increase, they've started seeing a 2-week decrease in number of cases. We would also expect that for countries like Tunisia and Equatorial Guinea, because of the capacities that have been built in countries over the past 3 years to be able to handle these type of surges. The factors still remain what we've seen over the world, the biggest being the population of people that are not vaccinated for COVID-19. So this is once again a push for us to get vaccinated as soon as we can. And whenever we have opportunities to get boosted, we should also go ahead to do that. Back to you, Mary.
Thank you very much, Dr. Opeyo Ogunduran. The next question is from Reuters News in Johannesburg. And this question is coming to you, Dr. Moeti. WHO is convening the emergency committee today on monkeypox. And to declare whether monkeypox is a global emergency. I guess the question is on whether it is a fake. What are your thoughts on whether this is going to be a global emergency?
Thank you very much for that question. I think like many of us, I'm eagerly awaiting the opinion of the expert committee on this. So if you forgive me, I would not like to preempt it with an opinion from somebody like me. But clearly, the fact that this group has been reconvened only a few weeks after its last meeting means that there is a very active discussion going on. And I think we are aware that the experts who met, there were some differences of opinion, which is not unexpected, on what exactly are the features of this particular outbreak that constitutes a public health emergency of international concern. Certainly, the spread of cases has continued, again, in an unusual pattern, mainly in Western countries, particularly in Europe, of a particular group of men. And we are seeing that the cases that have occurred in African countries have been particularly in two countries, in the DRC and in Nigeria. And this is something that we have been seeing in the region before, but we're concerned about new countries where this has occurred. So all I can say is that we are eagerly awaiting what will emerge from this group. We are very interested in the context of what we've learned from COVID-19, the implications of this for resources being available, tools becoming available in Africa to influence what has been regarded in the past as endemic situations, because we have seen a number of people dying from this disease, and we'd like those new developments, tools to be available in African countries so we can address this in ways that satisfy us, that we have an equitable approach when there is an outbreak like this all over the world, and confirm that all the lives of the people of the world matter. So let me just say that I look forward to hearing by the end of the day of the opinion of this group. If the declaration would provide opportunities for more focus, additional investment, that could only benefit us on the continent. And then finally to say that I look forward, of course, to following the trend that has evolved in terms of the investment in the development of tools and responses on the continent itself. That can be another legacy of the COVID-19 pandemic that we hope to see translate as far as this is concerned. Thank you.
Thank you very much, Dr. Moeti. Yes, we look forward to the decision of the committee. And this question from Elizabeth from the Guardian is to you, Mr. Is to the Gavi team. Would you agree that the manufacturer, this is relating to the RTS, was short-sighted in its failure to anticipate the gulf between supply and demand? And what action do you want to see to take it now and try to boost production? Feel free also to pass any question to your team, please. Mr.
Sure.
Kabano.
Dr. Stephen Sosler will respond to this one.
Thank you, Tobai, and good morning, everybody. Do we think that the manufacturer is short-sighted? No. I think that what we are dealing with is a new vaccine, and as a new vaccine comes online, supply is often in shortage. I think what we need to be looking towards is the efforts that we're taking to try to expand the manufacturing capability of not only the present manufacturer, because there is a technological transfer that is quite ambitious and that is going on between GSK and an Indian company, but also the late stage manufacturing from another manufacturer that we're anticipating will come online in the coming years. So we know that demand is there. We also know that we have challenges in terms of manufacturing, but we do see the ability to ramp this up in the coming years.
Mr. Steve, for that clarification. And this question is coming to you, Dr. Moeti, is from Adeline from Cameroon. If you can please respond to her in French. She's saying today, in view of the liftings of restrictions everywhere, does that mean COVID is over?
Ok, oui, merci pour cette question. Non, pas du tout. La pandémie de COVID-19 n'est pas encore finie, malheureusement. Ça continue, comme mon collègue a expliqué. Il y a même en Afrique quelques pays où nous avons vu comme on dit, une augmentation de cas. Heureusement que ça n'a pas duré très longtemps, par exemple en Afrique du Sud. Mais nous voyons aussi dans d'autres pays, dans des pays occidentaux, qu'ils continuent. En ce moment-là, il y a quelques pays aux États-Unis, par exemple, où nous voyons une augmentation de cas. Ce que je pense, c'est que la vaccination est une outil très important qui va aider à mettre fin et puis à gérer la situation. Et ce que nous conseillons comme l'OMS, que les actions excusez-moi pour mon français, les actions de lockdown, les mesures doivent être ajustées par rapport à la situation locale. Donc, ça veut dire que les données sont très importantes pour savoir ce qui se passe ici, maintenant. Est-ce que nous devons augmenter les restrictions ou bien nous pouvons, selon le tendance, comme on dit, rétablir la vie normale. Nous devons continuer à ajuster selon la situation pendant que nous continuons à augmenter la couverture de la vaccination, éviter les maladies, que la maladie soit sévère ou bien les décès, et continuer.
Okay, I think we have a little challenge with Dr. Moeti's internet. So the COVID-19 pandemic is still ongoing, as we have heard. Let's continue to get vaccinated.
La vaccination. Voilà, voilà ce que je dis. Malheureusement, nous ne pouvons pas dire que c'est fini. Non, pas encore.
Thank you very much, Dr. Moeti. We lost you for about a minute in between, but I think it's fine. So let's continue to get vaccinated and implement the preventive and control measures. The outbreak is still ongoing. So we are coming to the end of the press briefing today. I will turn back to our panelists to give us their final thoughts. I will start with you, Mr. Tabani, then Professor Leke, and Dr. Moeti finally.
Thank you very much. We did not talk today about the unique results that came out, which really show that a number of countries have stagnated or are backsliding on their immunization. It is an important effort and work that is before us that needs to be done. But it is also important to note that we are still operating in the context of a COVID pandemic that has not yet ended. The pandemic has not ended. Restrictions may have been lifted, but restrictions in themselves respond to more things than the pandemic. And we still have a pandemic to fight. Malaria has been a silent killer for many years, and the time is right to make sure that malaria is put at the forefront and responded to by all sets of tools that we have. It is unfortunate that the supply will lag and will be a struggle for a bit, but it is with this first step that we are excited that we are beginning a very important journey for protecting the children in Africa. And we hope that someday will come where malaria will not be a problem that causes many lives to be lost and creates a lot of morbidity. So with this, I think today is a significant moment for the health community, for public health, and for moving forward with a more comprehensive set of tools to respond to malaria. And we are up to the challenge. Thank you.
Thank you very much, Mr. Tabani, and nice having you on this press briefing today. And finally to you, Professor Leke, and in your final statement, if you could also, if you want to weigh in on whether the manufacturer of the vaccine was short-sighted, please feel free to do so. Over to you, Prof.
Thank you very much. The point I want to make is about the supply situation of this vaccine, because Africa really needs about 100 million doses. That's what we really would need. But for now, we're getting about 7 million to about 15 million, as we've heard. And that really, it's a major constraint. And you know, malaria vaccines, they don't have a high income market. I think so. it's a major problem for low and middle income countries. So the developers who pursue the malaria vaccine, they need to kind of be driven by a desire to reduce the suffering of children and families that are living in these areas, in these poorer countries. And that the pursuit of a vaccine against one of these major killers for children in Africa, you know, that should move on further than being motivated by, I don't know, high financial profits. So there is that. We all have to work in to see how we can get more of this supply. We have to understand today that there is really a constraint in this. And because of the constraint in supply, WHO did bring together, in response to this, then it brought together scientists globally in all areas to develop this framework, which we do have right now, the framework to ensure that children at the highest need across the endemic countries are prioritized to receive the vaccine as a start of the rollout. And then over the coming years, as the supply will ramp up and fully maybe meet the demand, you know, we will be able to get more. But the point I wanted to make is there is a real constraint in the supply. We all have to work out and have these partners really think about how we could increase supply. And then countries will have to work in the limitations of this framework that was developed. Thank you.
Thank you very much, Professor Leke. We appreciate your time on the press briefing today. And finally to you, Dr. Moeti.
Yes, thank you, Barry. First, I'd like to warmly thank my fellow panelists. Thank you so much for having joined us and shared your knowledge and information about what you are doing. And congratulations, indeed, thank you so much to Gavi for the efforts that have been made to improve the possibility of this vaccine becoming available. I can only add my own voice in terms of the advocacy. Again, that really to look at what this vaccine is addressing, you know, 60 kids dying in 24 hours, getting more than almost 1,500 children dying, you know, again, emphasizing it's outrageous. It shouldn't be happening. If it was happening on other continents, it would really be outrageous. So our familiarity with this disease should not cause us to think it's fine, it's normal, we can move gradually. So I think to create the possibility of decreasing the supply clearly will also require additional resources. So one can only appeal to others who are interested in the survival of children in African countries to also join in the financing. And we, I'm sure, will work together to make sure that the capacities for the production are there. And our task will be to ensure that every dose that is available is used in the operations and the campaigns integrated into countries where it is most needed. So thank you very much to our colleagues, the journalists, for having joined us. And I ask you also to join in our effort to spread that word, that it'll make a huge difference to African children, African families, African economies, if we get this tool and are able to deploy it at a good coverage. Thank you all very much.
Thank you very much, Dr. Moeti. I would like to say a big thank you to you and all the panel members, the experts, the journalists, interpreters, and our team here. Thank you so much. We look forward to seeing you next week. Have a nice day.
Thank you very much.